Hello and welcome to the Parkinson's Foundation Wellness Wednesdays webinar. The Parkinson's Foundation is a dedicated nonprofit organization committed to enhancing the lives of those living with and impacted by Parkinson's disease. We focus on improving care and advancing research, ensuring that all our efforts are closely aligned with the needs and priorities of the Parkinson's community. There are many daily challenges associated with Parkinson's disease that may lead to social discomfort and ultimately isolation. Today's webinar will focus on a few that may be less talked about. We'll discuss how each impacts the person with Parkinson's and address ways to speak to family and friends about how these visible symptoms cause self-consciousness and social situations. Today's program is sponsored by MERS Therapeutics. Thank you, MERS Therapeutics, for your generous support of the mission of the Parkinson's Foundation. To begin our formal presentation, I would like to introduce our presenter for today's webinar. Dr. Taylor Rush is a clinical health psychologist in the Center for Neurological Restoration at Cleveland Clinic. As Director of Behavioral Health Services, she oversees behavioral services provided by the CNR team of psychologists, social workers, and psychiatry providers. Her team sees patients with many different types of movement disorders, including those with Parkinson's disease. She spends time with patients helping them learn how to adjust to their diagnoses, cultivate social support, communicate effectively with loved ones and medical providers, manage symptoms of depression and anxiety, and emotionally prepare for surgery such as deep brain stimulation, get better sleep, adjust expectations for functional abilities, and practice mindfulness and relaxation strategies to promote physical and emotional wellness. Dr. Rush is a Legacy Mindfulness Mondays facilitator here at the Parkinson's Foundation. And want to thank you, Dr. Rush, for sharing your time and expertise with us on today's Wellness Wednesday.
Thank you so much for inviting me, Krista, and thank you everyone for joining us today. I'm going to go ahead and share my slides. Okay. All right, so hopefully all can see my opening slide, which is opening up on uncomfortable topics. And I will say that when I was approached about this topic, my immediate knee-jerk reaction was, oh my goodness, I really want to do this. And this is such a relevant and important topic for so many people who are trying to manage their Parkinson's as best as possible. So I'm very grateful to be able to share a little bit of my experience and the experiences that I've been able to witness and work with for many of my patients who have Parkinson's. Briefly, in terms of any disclosures and disclaimers, as Krista mentioned, I do join once a month for the Mindfulness Monday series and do receive a small remuneration for this. So I want to make sure that that is discussed. Our learning objectives for today is to, one, identify and discuss how some of the visible symptoms of Parkinson's impacts the person who's living with Parkinson's. And we're going to talk a bit about examples of how those visible symptoms may cause self-consciousness, social discomfort, embarrassment, shame, all kinds of things that often can become attached to these symptoms. And then we're going to talk a bit about how to explore approaching these symptoms with family and friends. There's no rule book on this that, tells us exactly what to say, how to say it, in what manner of speaking, and in what time frame for managing Parkinson's and having others understand what it is that you're going through. So we're going to talk about some guidelines for that. And then we're also going to make sure that you're aware of treatment options and strategies for the management of these symptoms, because sometimes there are things that exist that people aren't aware of, or maybe they forgot about. So I want to make sure that all of those possible options are on your radar. So let's begin. In terms of the visible symptoms of Parkinson's, this is kind of a sampling list that we're going to review today, but certainly there are more even outside of this. But for the sake of time and our presentation today, these are the ones that we are going to focus on. Tremor, dyskinesia, masking, dysarthria, and hypophonia. So speech that sometimes doesn't come out quite right, or the cadence is off and maybe a bit soft. Gait instability, so difficulties with walking, balance, the need for assistive devices, drooling, or the fancy term sialorrhea, and incontinence. And I have a picture up here of some poker chips and cards, because one thing that I'll sometimes say, half in jest, with many of my folks who have Parkinson's is having Parkinson's makes you a terrible poker player. Everyone knows your tells. This is a highly visible condition, and it means that oftentimes, whenever you're out in public, or you're nervous, or you're upset, it's more noticeable sometimes through some of these physical symptoms. And it means that people know more about you perhaps than you ever wanted them to know, especially if they're possibly strangers. And so you can kind of feel a bit on display, and it can feel like there's always an audience because you feel like you stick out, or things aren't quite the way that they used to be, and you can't trust your body the way that you used to. So these visible symptoms of Parkinson's can have far-reaching effects. And so we're going to start talking first about tremor. So tremor predominant Parkinson's affects anywhere from 60 to 90% of those who have Parkinson's. Oftentimes it can start very mild, almost imperceptible in a finger or a hand. And then over time, it can be much more visible. And even sometimes with medication, tremor can still be present. And for many of my folks who are initially diagnosed, and maybe they're just in their first year or two of their diagnosis, maybe they haven't yet started medications to help with tremor management because they're trying to hold off as long as possible for their own reasons. They may avoid certain social venues, or they may be highly aware of the tremor and concerned that other people may see it, especially if others aren't aware of their diagnosis yet. And a big thing that I hear is that I don't want others to treat me differently. I don't want to be pitied. I don't want to be, treated as if, I'm a patient. I'm still a person and who has a whole lot more to them than just their Parkinson's diagnosis. And so they find that they become very self-conscious, even by small, simple things like shaking hands, holding a glass, being at a buffet style social event, but just different things that they notice that they become more self-conscious about. I've had patients who do things that involve presenting or speaking to large groups for one reason or another, and being able to hold a microphone, or they have to keep their hands in their pockets because they don't want the tremor to detract from everything else, their message, their expression, what they're saying. So tremor can definitely be a disruptive and visible issue when it comes to Parkinson's. And then there's dyskinesia. So dyskinesia oftentimes happens when people are on certain Parkinson's medications, including carbidopa-levodopa. And it can be a bit different than tremor. It's a little bit more fidgety. People look like they're restless. They're kind of writhing, or their body might sway. And we see dyskinesia develop more in those who have had their symptoms for a longer amount of time. And again, some of this is contingent on perhaps how much medication they're taking. So, around 8% of those diagnosed for 1 to 5 years may have dyskinesia, whereas up to 66% of those who were diagnosed in the last 11 to 15 years can have dyskinesia. And there is something that we call peak dose dyskinesia, where when your medication is in full swing and maybe it's helping manage tremor really well. It's, helping you to feel less rigid, less stiff. You're able to walk better, is when the dyskinesia decides it's going to kick in part because of some of those symptoms, or some of those medications. And what I find that people tell me a lot is that when they're in the midst of some of this dyskinesia, other people may not fully understand what's going on, and they interpret it as nervousness, that the person is anxious about something. And because it can involve more than just the hands, which we often see with resting tremor, it involves the body, it involves shifting, moving. It can be a bit more noticeable than the tremor. And interesting, what I also find is that sometimes the dyskinesia seems to be more distressing or uncomfortable for those who are observing. Not that they're necessarily judging the person with Parkinson's for their dyskinesia, but they interpret it as possibly being more uncomfortable than the other symptoms of Parkinson's, like tremor and rigidity. And that observation that I've had has actually been echoed by some research where they were looking at patients as well as care partners' perceptions of dyskinesia. And in one study, they found that up to 84% of persons with Parkinson's actually preferred the dyskinesia during their on time with medication than no dyskinesia, but being in an off state from medication. Whereas up to, I think it was over half of the care partners preferred the off state versus the dyskinesia in terms of their level of comfort. And because they assume that the dyskinesia is more bothersome. So it's an interesting comparison from, the outside versus the inside when it comes to dyskinesia. And again, everyone's a little bit different. I have other patients who they really have trouble tolerating the dyskinesia. And so they'll lower their medications because they would prefer a little bit more tremor or stiffness rather than the dyskinesia. So it's definitely personalized, it's definitely individual. But in terms of some of what I see in general, those are some, observations. And then there's facial masking. So we often see with Parkinson's that facial expression can become a bit more muted. And again, with Parkinson's, this affects all areas of muscle in the body, so and including those in the face. So there's more difficulty with showing expression. People may not smile as much. Their face may be more lax, which can then actually be interpreted as someone being upset or disgruntled or angry. And it can create an interesting feedback loop because there's research that shows that when we give off a facial expression, the person seeing it then often matches it unconsciously. So if someone is smiling, you're more likely to smile back. If someone is frowning, you're more likely to frown back. It's part of us being social creatures by nature. And so it's an interesting feedback loop that if the person with Parkinson's isn't smiling or looks like they're in a bad mood, and perhaps they're not, perhaps they're having a great time, perhaps they're having fun at a social event, but they don't look it, then other people may approach them and match their facial expression, whether they realize it or not. And then the person with Parkinson's sees that facial expression and assumes that they're not happy or mad at them. And then it can make both people end up feeling bad. And sometimes what I also hear from those with Parkinson's is that they can get very frustrated with hearing the question, "What's wrong? Why are you sad? Why are you upset?" And they're like, "I'm not. I'm doing okay. I'm not entirely sure why you would think otherwise," because some of the feedback of understanding what our facial expression looks like can actually change too. So people may not realize that they're not smiling, even though they feel like they might be exhibiting some sort of facial expression. And then there's dysarthria and dysphonia. So these are fancy terms for difficulty with articulating speech as well as the volume and expression of speech. So with Parkinson's, we can often see that over time, speech can become more monotone, less expressive, a bit softer, and sometimes it can speed up a little bit. So when people speak, they speak a bit faster, their words run together. There isn't necessarily, quote unquote, punctuation between sentences. And that can make it hard to sometimes engage in conversation and communicate their points effectively. Because part of us communicating, it's not just what we say, right? It's how we say it. And so when there isn't voice projection, when there isn't emphasis on certain words, when there isn't a variation in our speech patterns, sometimes it's hard to discern what someone is saying and what the emotion is behind what they're saying. And so this can cause some difficulty in social situations, and especially, louder social situations. So there may be a lot of cacophonous noise. There's people talking, there's glasses clinking, there's other things going on. And if someone is speaking quickly and quietly, it can be difficult to hear them and to pick up on what they're saying. And that can get even more complicated when the person who's listening might have some hearing issues. So I can often see this with care partner spouses. If they have a hearing issue and their husband or wife or partner has, Parkinson's, and they have a lower voice, it's a lot of frustration between one person saying something and the other person not hearing them or saying what continuously over and over. And then when it comes to walking and balance and the use of assistive devices, we know that, up to half or more of those with Parkinson's end up needing some sort of assistive device. So the most common ones are walkers, wheelchairs or power chairs, walking sticks, something that allows them to be more mobile. And for many, there's a degree of self-consciousness that can come with this, because it's not just that they have symptoms of Parkinson's, but now they have this thing with wheels that makes it even more obvious that something is going on with them that requires help. And so they feel like it can bring on unwanted attention. It can end up causing them to feel much more aware of their social surroundings, and may not always want to go out in public as much because they're not sure if their walker or wheelchair will fit in certain places. Is the venue going to be too tight? If I wanted to go to the theater, is there going to be room for me to be able to do so with my walker? And if it is very crowded, people aren't always looking where they're going. And are they going to bump into me? Am I going to accidentally bump into someone else? Is this going to cause an issue, an embarrassment? And so that can definitely be top of mind for some individuals when they're trying to figure out how to use their assistive devices in the best ways possible. And another part of that is, if they are using some sort of assistive device that's a little bit heavier, so like a wheelchair, how do we get it in and out of the car effectively? How do we make sure that we can do that safely? Because sometimes the person with Parkinson's can't necessarily be the one to do it. And perhaps the others that are there to help them, maybe they have a bad shoulder, or maybe they have their own balance issues. So how can this be done in an effective and safe way? So all of these tiny logistical things that can add up to a lot of anxiety. And then there's drooling. And it's actually an incredibly common issue with Parkinson's and can affect up to 80% of individuals. And it's not actually that there is additional saliva that is being produced by your saliva glands. It's more so that your swallow reflex becomes less efficient. So many people feel like I'm producing so much more saliva, when in fact it's actually just that the ability to swallow your saliva becomes a little bit less proficient. And this can range, for some people it's, a wet spot on their pillow when they wake up in the morning. And for others, it's a constant battle throughout the day because there's saliva leaking from their mouth. And it can also sometimes complicate their ability to chew and swallow food or take drinks, depending on, how well that they're able to swallow. And sometimes the person with Parkinson's may not always realize that there is saliva that is visible, and others might point it out and say, "Oh gosh, you got a little something right there." And that can be embarrassing, especially if it happens, frequently, and especially if the person isn't always aware of the context of why the drooling is happening. And then when it comes to incontinence, we can see both urinary as well as bowel incontinence when it comes to Parkinson's disease. Again, Parkinson's affects all smooth muscle fibers within the body. And so within the bladder, it can affect how well the bladder is able to empty, and sometimes it can spasm without warning. We know anal sphincter muscles can also become less efficient at being able to hold tight. And so we can see these incontinence issues in up to 20% of our patients who have Parkinson's. And then we can see up to 40% that report some sort of urinary issue. So it's not necessarily incontinence, but they feel there's much more frequency and urgency with needing to use the restroom. So they may not have complete bladder emptying each time they urinate, or it just, because the bladder may spasm more frequently, it feels like there's an urgency, as if they're just about to burst, even if the bladder is not full. And so we can see this sometimes be an issue that happens more at night. And I have some patients who, they may take their last dose of Parkinson's medication at 6 or 9 o'clock at night. They may wake up at 3 o'clock in the morning and they feel pretty worn off from their medication at that point. And sometimes that makes it harder to retain urine or bowel contents. And so that tends to be a danger zone for some people. But then for others, it can also happen during the day as well, which can lead to fears of having accidents in public. And then there's this, preoccupation of, okay, so if I go to my book club, where do I know that the closest bathroom is? Can I make sure that I can get there on time? If I'm traveling and I'm going, a few hours south to visit my sister, is there a bathroom, along the way every, half hour to hour at a rest stop? And so sometimes that actually ends up to people saying, you know what, it's not worth it. It's not worth the risk. It's not worth the embarrassment. I'm not going to go to book club. I'm not going to go visit my sister because I just worry that something terrible might happen. So when it comes to talking to others, I often tell people, we got to start with how you talk to yourself, because these are very difficult issues to just discuss with people, and they can be very difficult issues for you to highlight for yourself. And I think it has to start with you better understanding how you feel about the issues that you might be experiencing with Parkinson's. And so, in terms of common themes of what we see, we certainly see that embarrassment is endorsed frequently. So in the research, it ranges depending on which study you read, but it can be up to 85% of those with Parkinson's. And embarrassment, I kind of want to define embarrassment and then be able to differentiate that from shame, which is next down on the slide. So embarrassment is when in any given situation where your symptoms are observable, for this case, for whatever reason, your behavior does not conform to what would typically be the social norm or expected, either from yourself or for others. And so it may be that, again, you're not able to project your voice, or you're not able to effectively hold a plate as you're going through a buffet line, or it's harder for you to maneuver and you have to sit down more because of imbalance. And so people who note embarrassment, it's usually contextual to the situation. And it's usually short-lived. So embarrassment is not something that perpetuates over time. It's usually very specific to a situation. And a lot of times eventually can be, moved past, sometimes through, laughing it off, sometimes through just explaining, why it is that something is happening so that way you can kind of move on. So embarrassment tends to be, temporary, and it tends to be, very specific to a situation. Shame, on the other hand, which can be up to, 25% of those with Parkinson's report shame. Shame is a bit more related to how you see yourself and who you are as a person. So with shame, there's often feelings of inadequacy, feelings that you're not doing something right that you ought to be able to do. And I hear that all the time from my patients with Parkinson's, that they will say, I used to be able to do, and you fill in the blank. I used to be able to ride my bike independently. I used to be able to, get dressed without any help. I used to be able to, work an entire day and still have energy left over at the end. And now things are very different. And it's not just objectively that things are different, it's that it challenges who they see themselves as in terms of, their character and them as a person. And because they feel that they no longer meet a certain standard or meet a certain expectation, there can be a lot of deep shame about that because they're not enough anymore. And it's not to say that that is objectively true, because I don't believe it is. But when you're dealing with a chronic health issue with a moving target in terms of symptoms that change over time, we can see this sense of shame attached to how one sees themselves. And then if there is that sense of shame, it makes it incredibly difficult to then talk to other people about it, because the things that we feel shameful of, we don't want to talk about. It makes us feel terrible. It makes us feel, vulnerable. And so, shame tends to not be something that we bring up very often, even though once we do, it often starts to wither a bit. And we'll talk about that in a minute. And then there's stigma. So stigma is a bit more on a social level. So stigma is someone being treated differently as a result of something, as a result of, I have patients who have depression and they feel stigmatized because if others know that they have depression, they feel that they're treated differently. Same thing with medical conditions. So my patients who have Parkinson's sometimes are very hesitant to tell other people that they have it because they don't want to be treated differently. They don't want to be seen as less than. They don't want to be seen as different or special, not in a good way. And so there can be a lot of stigma attached to having a chronic medical issue. And I think, especially in our culture here in the United States, there's a very ableist bias to everything. So everything is based on the assumption that someone is able. And when someone isn't able, then there's something wrong with them. And that's where the stigma lies. So I think being able to understand and acknowledge and call out stigma ends up being very important and very powerful. And then vulnerability. So vulnerability means that, someone understands or knows something about us that we find difficult to accept ourselves, that we're honest with ourselves and others about how we feel about things, even when it comes to emotions that maybe we find really, really difficult to confront. So again, it could be shame, it could be sadness, it could be anger. And so to be able to talk about these symptoms, these visible symptoms of Parkinson's, means that we have to be vulnerable and recognize that there is strength in being able to talk about those things that we find difficult. And then the other thing I think is important is acknowledging the fears that you may have associated with talking about these symptoms. So for many, I hear this often, there's a fear of losing independence, losing the ability to take care of oneself, losing autonomy and the ability to make decisions for oneself. A big one around that is sometimes driving. And so, being able to make sure that you remain as independent as possible, I think is everyone's goal. But I think there's always a fear for people that, if they lose independence, they lose a part of themselves, and that others may, again, then see them differently. And so, a question that I will ask folks sometimes, especially as they're trying to come to accept their Parkinson's diagnosis, or they're coming to accept, some intensifying symptoms that are beginning to develop, and we talk about, okay, so if you have to pace your activity differently, or if you end up, having to need some sort of accommodations in a social situation, what does that mean? Oh, well, it means someone has to, make a fuss about me, or it means that, I might be a burden on someone, or it means that, they're going to see me differently. Okay. So what does that mean? If they see you differently, or if they do have to, help you out, what does that mean? And a lot of times what it ends up boiling down to is, again, how the person sees themselves. It means I'm not who I was. It means I have to acknowledge the grief that comes with change with my Parkinson's. And so I think these are important questions to ask yourself, because this then helps to inform how you then are able to approach and talk to others. Because once you can talk to yourself about this, it becomes easier to be explicit with what you need and how these things affect you to your loved ones. So in terms of talking to yourself, a couple of pointers, and again, this comes up a lot for folks that I see in therapy, is, one is, how do you calm your inner critic? And this is something that we talk about sometimes on Mindfulness Monday, is acceptance and self-compassion. And how do we listen to that narrative of our critic, but not always, believe everything it says? And so one question to ask yourself is that when you notice that you're being very harsh on yourself about your symptoms, about management of your symptoms, would you talk to a friend that way? Is that how you would talk to them about their symptoms if they were dealing with what you are? Most of the time, the answer is no, because we tend to be much more compassionate, much more understanding of other people's issues than our own. We tend to sometimes be our own worst enemy in that sense. But sometimes, if we're able to speak to ourselves in a way that we would speak to others, we can start to foster a little bit of self-compassion. And honestly, I think that is one of the key ways that people end up managing their chronic health issues, including Parkinson's, successfully. Recognizing thoughts that might be limiting you. Are there things that you're assuming that may not be true? Are you assuming that you're a burden to others? Are you assuming that others see you differently? Are these factual, or are they fears? So a lot of times, when I'm working with people, we might do kind of a T table, right? So we got facts versus fears. What is the facts of a situation versus what do we think the fears are that might be misconstrued as facts? And how do we challenge those in a way that's constructive? And then also acknowledging areas where you might need support. And sometimes that's emotional support. There are individuals in your life that you can talk to that can provide, an ear. And that's all you need. Sometimes all we need is a witness to our experience. Sometimes all we need is someone to hear what it is that we're going through. They don't have to fix it. They don't have to, provide profound wisdom. It's just that we need them to hear what we're going through. And then sometimes we need more instrumental support. We may need help with getting that wheelchair in and out of the trunk of a car. Sometimes we may need help with transportation. Sometimes we might need help with getting things done around the house. And so sometimes objectively looking at what are the areas where I could really use some support, and who is it that I could possibly ask for this support. And so again, I bring it up twice because it matters that much. Practicing self-compassion, supporting yourself as you would someone else, because I think, again, we think, gosh, it's mind over matter. I just need to grind through, and I don't need compassion. I need, someone to be, Bobby Knight. And I don't think many of us benefit from the Bobby Knight in our head. I think we need, a little bit of a kinder voice. We need to be able to offer ourselves, hey, I'm struggling with things here, and this is really hard. And this is, something that not just I am going through, others are going through it too. And it's okay to be kind. And then I think remembering that your symptoms do not equate to your worth. So your symptoms are not a reflection of who you are as a person. They're not reflective of what you've accomplished. They're not reflective of your value as a human being. And so, so often we think, what's on the surface, is what we're getting judged by. But for those that really matter to us in our lives, that is not what they care the most about. And then I think remembering that many things you feel might be amplified compared to what other people see. So a lot of times people may feel very self-conscious about, their tremor or perhaps drooling or other things. And we think it is so on display and that's all other people can see, when in fact they may not notice it at all. Or if they do notice it, it's not really something that bothers them and they kind of tune it out. And I will say, for me, I work in movement disorders. I see people who move all day long for one reason or another. And so to be able to, I just kind of tune it out. It's not something that it even really registers for me at this point because it's just part of my world. And so our brain is actually really able to filter out things that we don't find relevant, or it's not, information that we really need to process. And so when people are talking to you, that may not be what they see at all, and you may see it much more profoundly than they do. And then how to talk to others. So when you're talking to others, after you've kind of sorted things out a bit more for yourself, I think it's important to be as direct and simple as possible. And so if there is a certain symptom that you want to talk to others about, I always encourage a proactive approach. So talking to someone about it ahead of time. So let's say you have a social event that you're going to, and a loved one or a friend is accompanying you, and you want them to have a heads up about something. Bring it up, educate them. So saying, a symptom of Parkinson's you may not realize is, and you fill in that blank. You can talk about, the dyskinesia. You can talk about, some of the speech issues or, other things that are bothersome, and then share your experience with that symptom and say, this has been difficult for me because it's hard for me to project in a busy room and to be able to clearly communicate to people at a dinner table, or it makes it difficult for me to feel like I'm not on display because my tremor is visible while I'm eating. And then make a specific ask. So one thing I could really use some help with is I could really use some help with, maneuvering my walker in and out of the car. I could really use some help with, you fill in the blank, So I could really use some help with maybe you prompted me, hey, smile. That would, help me, just if you kind of smile at me, and that would maybe help me prompt to exaggerate my facial expression so that I can, look as engaged as I feel. So, think about what it is that you want from people, because oftentimes people are more than happy to help, especially if you give them a roadmap for how to help. So, it's one thing to be, ambiguous and say, gosh, I really need help with something. But if you give them specifics on how they can help, it often can make the situation go much, much more smoother. And I think it's important to remember that these are not necessarily comfortable conversations. Oftentimes you have to step outside your comfort zone to discuss them, because it really takes courage to be vulnerable like this. It really takes courage to be able to talk about these things that are bothering you and that can be witnessed by others. And again, when we're bothered by something and we don't talk about it, it tends to amplify. And so shame tends to thrive in the dark. So when we don't disclose things, when we're disconnected, when we kind of keep all of that in, it ends up really giving some fertile ground for the shame to grow. But when we talk about things, and oftentimes when people come in to see me and they're like, okay, you're not going to fix my Parkinson's, so I don't know exactly what you're going to do to help me. And we talk about the power of giving voice to your experience. Being able to talk about these things out loud doesn't make them go away by any stretch, but it does take away the power of the shame. So shame thrives in the dark, but connection is what grows in the light. And so being able to have these conversations with others, while upfront might be uncomfortable and difficult, can help to fortify your relationships, to help people better understand what you're going through and how they can be helpful. And for you to be able to make sure that you get your needs met, both emotionally as well as instrumentally. So management strategies. So I want you guys to really inventory all treatment options that are offered to you. So when it comes to the medical side of things, talk to your neurologist about everything, okay? I know that a lot of times they're not long visits, but bring a list and make sure that they're aware of all the things that you're trying to deal with, because sometimes people don't bring everything up. They don't necessarily bring up, that they're having, some drooling difficulties. They may not necessarily bring up some of the speech difficulties. And so, you need to make sure that your neurologist is aware of all of this, incontinence issues, everything, because there are medical options that can help with some of these things. There are things that can help with tremor. There are things that can help to, reduce, the likelihood of severe dyskinesia. There are injections that are used to help with the drooling. There's, all kinds of different orders that they can place for other therapies in order to make sure that you can get everything addressed as well as possible, or be able to make sure that referrals are in place with other specialists like urology to try to help with some of these issues, and sometimes ENT and otolaryngology, because they can help sometimes with some of the vocal issues. And then I really can't underemphasize the importance of physical, occupational, and speech therapies. It is transformative. They really are. I have seen patients go into physical, occupational, and speech therapies who are having a lot of balance issues, a lot of soft speech, a lot of difficulties with day-to-day tasks. And they come out of these therapies so much stronger, so much more able to do the things that they need to do in their life, and able to feel more empowered about what they can do. And so there are specific protocols for big and loud interventions, the LSVT, the Silverman protocol. So there's a ton that people can do in order to try to help manage these symptoms. And then, psychological intervention. I am, one provider of many now in our center, because we truly, I think, value the importance of attending to people's emotional well-being who are managing Parkinson's. So to be able to meet with a psychologist or a therapist can help you to better understand some of that internal dialogue, some of that attached, strong emotion of, sadness, of anger, of embarrassment, of shame, and better be able to address it and turn it around a little bit. So definitely, if you notice that those are strong themes for you, that can be an incredibly helpful intervention. And then other things to consider is, when it comes to the logistics of any particular social situation or travel, try to plan things out ahead of time. So maybe it's that you need to leave a little bit earlier to accommodate, some, less efficient, slow speed that you might have. Maybe you need more frequent breaks. So I have people who, they'll go to a social event, but they need to take a time out. They need to make sure that they can kind of have a little bit of space and a little bit of quiet to be able to kind of, readjust themselves a little bit. Maybe sometimes take a break to take medication, let it kick in for a little bit, and then reemerge for, part two of the social event. Making sure that there are chairs available, making sure that there's, some sort of accommodations in place to make the situation as comfortable as possible. And, with travel, air travel, for instance, I often recommend patients, to use the assistive services that are through, that particular airport, because a lot of times there are things there that people don't even know exist. And so ask for the help that you need. And it may look very different than how you've been able to maneuver situations in the past. It may look very different in terms of, what you're able to do or what you need help with. But that doesn't mean that it's bad. It just means that it's different. And you don't need to apologize for accommodation. If you need help with something, or you need to make sure that you have something available for yourself, so like, making sure that there are chairs available, making sure that maybe there's wide enough spaces for you to get through with your walker. We are meant to be collective as human beings. We are not meant to live in isolation. We are pack animals. We are meant to help each other. And I can imagine, for those of you who are hesitant to ask for help, have probably given many other people help in and throughout your life. It's a two-way street. And so if you're going to give it, you also have to take it. And then I think it's important to also not forget the importance of humor. And I had one patient who had tremor, and in social situations, it was a rest tremor. It was fairly obvious, unless they had their hands stuffed in their pocket. And so they would try to make a joke of it and just say, "Hey, do you want that drink shaken or stirred?" It would lighten the mood. It would create some levity, and by them calling it out and bringing attention to it, they had power. They had the power to do what they needed to do, to call it out. People understood what that meant, and then they moved on, and it was no longer, the pink elephant in the middle of the room. So a few key takeaways. There are many Parkinson's symptoms that are uncomfortable and visible enough where it can, have the potential to create some embarrassment. And honestly, they're best managed by openly discussing them with the people who care about you and creating a plan of action to try to help manage them. So utilizing social support and your medical team, it not only leads to better symptom management, but it enhances your quality of life. It can help promote emotional well-being and connectedness. And we know that those are independent factors for successful management of medical issues, especially Parkinson's. So use all of that to your advantage. Make sure that you recognize that you're part of a team. You're not just one person trying to take this on. So use what you have to your advantage as best you can, because you deserve it. Okay. Thank you so much. I will stop sharing my screen now.
Thank you, Dr. Rush. Appreciate all that you do in the Parkinson's community, and how you support us in living a quality life with Parkinson's and affected by Parkinson's. So I saw a lot of tips and tools here for the care partner as well. And I want to acknowledge and celebrate that you taking the time to offer information, education from the perspective of a care partner as well.
Absolutely.
Quite a few questions from our community, and want to thank everyone who's present here today to learn about uncomfortable topics. I was speaking with my colleagues prior to what I call we lifted the curtain to our webinar today, and how these conversations of uncomfortable topics aren't really welcomed in conversation. And then when we bring these webinars like today on this subject, the community shows up. So I want to applaud everyone here who's leaning into these uncomfortable topics to be able to take some key takeaways home and have those conversations with the important people in your life to continue to live well with Parkinson's. We have a community member, Christine, asking more about dyskinesia and hoping that you might be able to address this, Dr. Rush. She's curious, how can I tell if my dyskinesia is because I'm having an off time? Are there ways to determine otherwise?
So typically, people will notice dyskinesias as they kind of align with their Parkinson's medication dosing. So if they're on some sort of carbidopa levodopa formulation, they'll often notice that as the medication starts to kick in, that they will start to experience dyskinesias. And so that's often, kind of the overlay of dyskinesia is with the timing of medication. And then, it can, for many patients, how they describe it to me is that it feels very different than their tremor and their normal symptoms that they might have if they're off medication. And so for them, there's a distinction in terms of just kind of the feeling of the symptoms as well. And so, I would say that if you're having trouble distinguishing that from tremor or other parts of your Parkinson's symptoms, that is definitely a wonderful question to bring up to your neurologist when you see them, because they are a wealth of information as it relates to when and how some of these symptoms take place, and then can maybe offer, changes in medication timing or dosing to try to improve any dyskinesias that you might be experiencing.
Thanks for that guidance, Dr. Rush. Jim joined us a little late and is asking a really good question as far as Parkinson's affecting our energy levels. Could you speak to how Parkinson's may or may not affect the way that we feel energized or fatigued?
Absolutely. So that is an incredibly common issue that I hear from my folks who have Parkinson's. And it we know that happens for many reasons. So one is that because of the symptoms that you're dealing with, so if it's tremor, rigidity, or even, some of the side effects of medication like the dyskinesia, it takes more energy to do normal things. And kind of how I describe it to people is that, we all have a backpack that we carry of stress, of obligation, of, things that we have to do. And when you're trying to manage Parkinson's symptoms on top of that, it ends up being extra bricks in the backpack. So, the normal walk that you might take every day takes more energy because your backpack's heavier. And so, fatigue ends up resulting. And so, I often will say, you have another way of thinking about it is you have a smaller gas tank than you used to. So you're going to run out of gas sooner than you normally would in the past. And therefore will sometimes need to take more breaks and may not be able to expect as much to get done on a day-to-day basis. And so I think that's a really important thing to bring up, because while the fatigue itself is not necessarily a visible symptom of Parkinson's, the effects of the fatigue might be. So someone may say, gosh, I used to be able to mow my entire lawn and weed my garden and clean out the gutters and do all these things. And now after I mow the lawn, I'm kind of done. And so what is seen is less productivity, less things that they're doing. And then their loved ones are like, well, what's going on? You used to be able to do all these things. And, I think there's an implicit judgment there that we're not doing enough, or we're being lazy, or, something's not right. But again, I think that's where the education comes in, that, hey, one of the effects of Parkinson's is it does affect my energy level. And therefore, the things that I'm able to do, in a day, or, for a certain amount of time may look very different than it used to. And so it ends up being an important conversation to have about expectations. So yes, that definitely is an incredibly common issue that people run into with Parkinson's.
I think it might be important to also bring awareness to the effect of energy levels for the non-visible symptoms of Parkinson's, such as depression and anxiety. Could you speak to how that might implicate our energy levels?
Absolutely. So when, and we know that depression and anxiety are incredibly common with Parkinson's as well, can affect up to 30 to 50% of those with Parkinson's. And when we are feeling depressed, there's two pieces to that I think are important to remember. One is the physiologic piece. So we know with Parkinson's, there's already, less dopamine in the brain, and with depression, that tends to amplify even more. And when there's less dopamine, when there's less serotonin, it affects everything: dopamine, serotonin, norepinephrine. All of our neurotransmitter volumes tend to become askew, and that can affect fatigue significantly. And then also because we then have a lot of, pervasive negative thoughts when we're feeling depressed, we feel less able, we feel less, enough. And then, and it doesn't matter if I do these things, it's not going to, it's not going to work out, or it's not going to be the way I need it to be. There can be a lot of defeating, fatalistic, and negative thoughts that come with depression. And so those things also can weigh you down, and that affects energy levels as well. So it can happen on a physical level as well as, a cognitive emotional level that just kind of seeps us of any energy that we would normally have in reserve.
So I would just caution in thinking about, is this low energy level due to the physical symptoms of Parkinson's and I need to take the break? Or is this a symptom and reaction of how I'm feeling in my depressive state or anxious state? And really deciding what's best for you and what you need in the moment when you're feeling this low energy.
Yeah, absolutely. And some of it, and that's sometimes I'll get referrals from the neurologist in my center to kind of help tease that apart a bit. And how much of it is, that the person is having thoughts that may be contributing to some of that lower energy and low level of activity, because a lot of times it's, well, why bother, what's the point, and other thoughts along those lines, versus those who are like, no, I'm really trying, I really want to do these things, there's interest, there's motivation, but then physical capacity just can't keep up. So sometimes we're looking for those differences in approach.
So, Dr. Rush, today's conversation on uncomfortable topics was focused on the visible symptoms, and now we've kind of leaned into the invisible symptoms. And there is a question from one of our community members here about sexual dysfunction. And this is a conversation that is often had in closed rooms, indoors. And when we speak about it, we find that a lot of the community is really struggling with intimacy or sexual dysfunction in the bedroom, or even feeling close to their loved ones. Could you speak a little bit about the sexual dysfunction and how to navigate that uncomfortable topic?
Sure. Yeah, and this is one again that comes up often, and it is often behind those closed doors of therapy. But then people are talking to me about it, even when they're not talking to their spouse or loved one about it. And because I think that does connect to, for a lot of people, to a deep level of shame. And physiologically, we know that Parkinson's can affect sexual functioning, and we can see in men it affects their erectile function. It can affect ejaculation. It can affect women in terms of their comfort level with any type of intimate interactions. We know that again, with dopamine production being a bit askew, it affects our reward center of our brain and our desire to move towards certain types of activity that we usually find inherently rewarding. And so, there there are various approaches to this, and I think it honestly depends on the context of the relationship that you have with your partner, because sometimes there's a context where talking about anything that is vulnerable has not been well precedented in the relationship, even if they've been together for decades. You just kind of ignore it and try to move on. And in those relationship dynamics, it ends up being a really hard topic to broach because there is no precedent for it. Whereas in other relationships, there may be a little bit more of a, of an established pattern of open communication. And how do we then just, use those skills to then maneuver this particular situation? But I think some of the main themes that tend to come up are recognizing it's not a lack of love. It's not a lack of interest in the person. A lot of times it's these physical issues that then, create differences in how one can display intimacy. And so then we have to explore, well, what else can intimacy look like? How else can intimacy be shown if it's not able to be shown in the ways that we normally would? And again, I think that's also a discussion to involve your neurologist with, because again, sometimes there are certain medications and treatments that can help with some forms of dysfunction that happens sexually. So, but again, it's one of those things where, I think we have to establish the fact that it's not anyone's fault and there's no finger pointing involved. It's not, you're not doing enough for me or I'm not doing enough for you. It's, hey, we have this issue. How do we work through it and make sure that we can both get our needs met in the ways that matter to us? And how can that tap into our values as a couple? So that we could do a whole talk on, I think, in and of itself.
And I want to thank the individual who asked this question. This is a bigger subject that really implicates our quality of life and our quality of relationships with the people that we love. And so I encourage you to seek counsel, and to look for some of the resources that the foundation has on Parkinson's, sexual dysfunction, and intimacy. And I'll ask my colleagues to please provide those resources in our event email that we'll be sending out next week. Dr. Rush, I want to respect the time that we have. It is 2 p.m. Eastern time, and we have some really good questions in the queue right now. Do you have a few moments to spare with us?
I can spare a few, yes.
Let's do 5 minutes.
Okay.
Mike is asking, he's sharing rather, that his wife is refusing his diagnosis of Parkinson's disease. She does not want to accept it. And this is because of his physical limitations. He's not able to meet her social expectations. How do I deal with this? How do I navigate the expectations of my loved one?
That's incredibly tough. I'm sorry that you're going through that because ultimately it's a denial of reality. And I think that ends up wearing on everyone involved. And so for you, I can only imagine how invalidating that must feel. And at least I would imagine that's how you feel because you know what the reality is because you're living with it in your own body every day. And so to have someone who isn't yet willing to accept the reality of the circumstance can be incredibly challenging. And so usually in circumstances like this, there is some sort of fear that the other person has that just feels too overwhelming for them to face. And so, I I've had a few situations like this where I've then invited the partner to come into the therapy room with the person with Parkinson's so that this can be discussed further because I'm not here to assume or extrapolate any possible reasons why your wife may be feeling this way, but ultimately it is going to need to have candid conversation with her because you can only do what you can do, and it doesn't mean that your shift in your abilities is wrong or you're not trying hard enough. So I do want you to know that it just means that the expectations may not necessarily now be reasonable or appropriate. And that's something that is going to have to come to terms with for you and your wife. So I'd highly, highly recommend that you find someone that the two of you can talk to about some of this because it's going to require some candid conversation. And if it's hard for you guys to navigate this on your own, having a third party as an intermediary can often help significantly.
Thank you, Dr. Rush. I appreciate you offering us a little bit more time past our time, and appreciate all that you do to support us through our navigation of this journey in living with Parkinson's. I want to address that there are a few questions in the queue about dyskinesia. As Dr. Rush suggested, please reach out to your neurologist or your movement disorder specialist to receive some guidance about dyskinesia. And Christine, I saw your question about how to stay calm, how to get calm. I invite you to join us for Mindfulness Mondays. We move through all kinds of tools and tips and tricks that you can use to to find that calm state of mind that goes beyond just deep breathing. So thank you, Christine, for asking that question. Dr. Rush, thank you for offering your time and your knowledge for today's Wellness Wednesday. Can't thank you enough. And a big thank you to each of you who joined us for today. The Parkinson's Foundation hosts weekly education and wellness programs through PD Health at Home virtual programming. You can join us for Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays. Our next Wellness Wednesday will be hosted live on Wednesday, August 21st, and we'll focus on speech and swallowing and Parkinson's. So that's some of the subjects that Dr. Rush had pointed out for today's presentation. Most people with Parkinson's will experience changes in speech, voice, and swallowing at some point during the course of Parkinson's. So next week, we'll be learning tools and exercises that can help us better understand and how to manage speech, swallowing, and communication challenges in Parkinson's disease. For your convenience, most of the PD Health at Home programs are recorded and posted on the Parkinson's Foundation's YouTube channel. You can scan the QR code on the screen to connect to our YouTube channel. You may also find out more and register for our live programming at pdhealth.org, parkinson.org/pdhealth. And I'd like to invite you to join us this Friday for our Live Fitness Friday session with our friends Ben and Dan with In Motion Fitness Center. This week we'll have a fun, fast-paced, and live workout that will target large muscle groups and universal movement patterns that will address agility and symptom-focused bending and lifting. You can sign up to attend the live stream at parkinson.org/pdhealth. Today's program is sponsored by MERS Therapeutic. Thank you, MERS Therapeutics, for your generous support of the mission of the Parkinson's Foundation. We did receive lots of really thoughtful and intentional questions today. Unfortunately, we weren't able to get to them all. Please do not hesitate to reach out to our helpline at 1-800-4PD-INFO. You can email our helpline at helpline@parkinson.org. There's all kinds of resources on our website as well, parkinson.org. Until then, my friends, be well, and I hope to see you in our future programming.